Applause for Jeanette. Perhaps we can give her a clip from the live stream or something, Zoe, so that she can see that people were very, very pleased to honour her retirement. And finally, we come on to the team of the month for April 2022. And this is very Regis Central Community honour her retirement. And Laura, are you representing Regis? We come on to have I got it right? No, anyone from Regis? And this is very Regis Central Community honour. Laura, are you representing Regis? We come on to have got it right nomination for anyone from Regis? Smith. And this is very Regis Central Community honour. No, the team are you representing Regis? And hard-working always and especially when we know colleagues tirelessly and hard work and how it is students colleagues despite the challenges and how we find a positive environment and we said that the highest ideas leads to the challenges and how they responded and developed this academic and growth and maintaining we said that the highest is being optimistically confident, not just on patients but certainly as students develop this academic and examples of those faithfulness, learning expectations. I have not met a great deal like this before. Kindness and examples I've met. A credit to that learning expectations. I appreciate your kindness. Bless your big, beautiful heart. That is a wonderful accolade there, Jennifer. So I'm really pleased that you've got the team of the month available. Please pass that congratulations back to your team. I think there might be some people in the room with you, although I can't see them. Many congratulations. And another round of applause from board. Please pass that congratulations back to your team. I think there might be some people in the room with you, although I can't see them. Well done, everyone, for those accolades. You can, of course, continue to observe the trust board, but you may have other things you need to be getting on with, and we fully understand that. So may I wish you a very good day. Thank you once again for all you do on behalf of patients. You may have other things you need to be getting on with, and we fully understand that. So which takes us on now to the business agenda, and let's just do some welcomes and introductions. I think, Zoe, we have apologies to Rebecca Cook and Sarah Longfellow, business agenda, and as I said earlier on, we have David and Mark online with their various ailments, both speedy recovery. And also a welcome to Lloyd Barker, Lloyd's joining online. I'm going to take us on, if there's not any declarations of service, to the minutes of the previous service that held on 31st of March. And inquire if there are any points in terms of the minutes and now correctness that held on 31st of March. And inquire if there are any points in terms of no comments. So we're happy to accept the minutes as a correct record. Excellent. That takes us on to the action log. The first one about viable outcomes, the minutes of corporate objectives. We're coming to that on the agenda soon, so I think that takes most that one. The second action is to review the integrated performance report to show trend data more widely across the report. And again, we're going to come to that. My second action is to set then, so I think we can take that one. The third action is about confirmation that widely provided within the integrated performance report when there are 15 plus completed risks. And again, we'll come to that integrated performance report. And finally, there's an action there when there are relatively strong to review the format of the serious incident, patient safety and RIDDOR report. Again, I'm actually going to be talking about that later. So
was completed and that report went to Quality Improvement Committee last week.
The outcome of RIDDOR report.
That it was a much better report and engaged more people.
So we're content with that action.
Absolutely.
That's good. All those actions therefore closed, and that takes us on to the next section of our agenda, which is around strategy and corporate objectives and the board assurance framework 21-22, looking back and looking forward to corporate objectives 22-23. Siobhan.
Thank you, Peter. So as the cover sheet states, we're asking here for the board to note the corporate objectives and BAP, and then I thought perhaps, Peter, if it's okay with you, I'll pause after that before we move on to the approval of the forthcoming corporate objectives. So I guess guess, it's important for us to remember what type of year this describes, really. And colleagues will remember that there was a whole heap of uncertainty at the start of the year in March, April 21, and therefore we split the year into two. So we had half one and a half two. So I guess the first thing to say is we preserved all of the corporate objectives and we slightly changed the value and sustainability one. So it ended up being a year's worth of effort in the areas that you can see. I mean, I think from my perspective, we should, as an executive, be really proud that we managed to deliver so much amidst the adversity of the various waves of the pandemic. On corporate objective number one, we had a constant focus on the well-being of our people over the course of that year. Caroline and I had a conversation earlier in the week, and I think we've learned a bit from the way that we tried to evaluate this. So our reflection is that although it says we would achieve this by making sure that 85% of managers were using the Healthy Teams checklist, I think we have learned that a more qualitative analysis of the impact that the Healthy Teams checklist has had on our people would be the type of work that we're going to enter into this year. So whilst it says fully delivered, board members might know that on a couple of the bullet points, it probably doesn't actually give assurance that 85% of our managers are using it. I think we realised that probably was the wrong measure, and that the impact of the tool is what we want to find out, and Caroline and her team are going to undertake that work this year. The only other one I was going to draw the board's attention to is corporate objective number 4, which is partially delivered. So again, this is a good example of, I guess, entering into a piece of work, and Kate and I discussed this also earlier in the week. The objective here is to deliver better outcomes for patients by improving the management of our waiting list. And actually that was born out of the piece of work we did around restoration and recovery. So on that cusp of between year 1 into year 2 of the pandemic, there was a big national drive to completely understand the quantum of backlogs of care and to start to put improvement methodologies in place and to really have clear trajectories to reduce the number of people waiting, but also, importantly, to improve the experience of those people who are waiting for longer than would ordinarily have been. So this, throughout the year, then evolved into what we describe as the waiting list project, which is a big P1, i.e. the most important priority for us in this year, programme of work that involves pretty much all of the executive team. Actually, there's a really significant data work stream within the waiting list project. Lloyd is leading that for us under Kate's exec SRO leadership. And I think what we realise is that this was a massive undertaking that is never going to be achievable in totality within any one given year. So whilst it's partially delivered, just to provide assurance to the board, you will probably see this manifesting through some of the strategic goal discussions, and the way that we undertake our strategy deployment now will be focusing on waiting lists as, I say, one of the top priorities in the trust moving forward. I think what we realised is that this was anything else. I was going to move on to the back, but I'm happy to pause there, Peter, and see if there's any questions on corporate objectives in totality within any one given year. So whilst it's partially delivered, just to provide assurance to the board,
the amount you've achieved in the year that you've had against these objectives, and absolutely, there's no doubting the work that's under the bonnet. I really like the way that you've described the fourth objective there of it's such a massive undertaking that's never going to be delivered in the year.
I think what
when I look at objective 2, I don't know whether I feel the same about that.
A massive
I think it kind of starts off with showing that we'll be able to deliver equal health to all. That's a phenomenal objective, and I think if they're fully delivered, thank you for all quite a struggle. I commend you to completed all of the tasks that you set ourselves under against these objectives, but I'm not sure we've fully been able to deliver that objective on the overarching bit. And certainly I think there's been a couple of times of quality improvement around the fourth objective where the data, and particularly I think on the back massive That's just one of the other ones. One of the objectives to run away, I think, the same thing that described. That's how you get to measure objective for delivery equal health. I probably apply that same test to phenomenal objective too. There's no doubt that this is the feet running under the quite a struggle. But when we completed all of the tasks that you set ourselves, sections of the community that we've tried to make a difference for would feel it. I don't know whether you would say that objective too. There's going to be a couple of
I mean, I think it's a really good point. I guess it's Sarah was here as the exec owner. She would probably say the objective was living with some milestones that had been delivered. That doesn't mean we have achieved the end of the road, which you're absolutely right about. I think, again, you're right, there is a lot of similarity with the way we project. This was way more complicated, way more data driven than I think we and complicated data driven than we probably do. So I'm happy with what they have delivered. I agree that the task was delivered, but the totality of the ambition to understand segments of our population is far from delivered. I'm happy to take that decision in Sarah's absence as the owner, and that we minute that whilst the tasks that were the milestones for this specific objective and how it was written were fully delivered. The programme of work that needs to go way deeper and will take much longer, and therefore it doesn't feel like it's totally delivered. But if they have delivered, I agree that I think
we're looking at 22, 23 corporate objectives. So I guess that leads us to make sure we're absolutely clear in our description of the headline objective, because I think we always in our hearts is a multi-year program. Probably we want to be ambitious, but we may have overstated our ambitions in the way we drive corporate 22 overall, if we have reflected on the milestone. So I think that, yeah, absolutely partly delivered on that overall objective, but hitting the milestone in the design of the wording in a way that showing what was deliverable in year.
I think it's sorry, in fairness, you kind of caught to that bit of the total difference versus will improve. You know, one patient will come out of the report and you get the target, either of that bit of will improve or do whatever. There's a bit of a semantic challenge to that's what I mean. The 22 overall objectives. Just make that one last thing. So I think, yeah, we've learned from this one having that overlap between ambition and delivery. We're saying that in a way that's not quite fully. That's partly good, sorry, and the lesson going on 22 bit to be clear about the extent of what was expected within. That's what I was thinking. Yeah, it's a lesson learned.
Mine was the same question as yours, really. It was around outcomes on that objective. So again, I'm really pleased that we're down the path of the objective. So okay, yeah, fair enough. I agree. Yeah.
Any further questions before we move on to that?
Thank you. So with that, board colleagues will note that there's 2 closed risks and 2 new risks, and so we felt it was really important to start to contextualise the description of our back risk with a bit more clarity in terms of the context that we're in now. So I'll start with the new one. So colleagues will see that we've closed system fluidity, which actually has been one of the chief execs back risk for a number of years now. And it's interesting thinking back how much has changed around us and how fluid our external world has been for quite some time. And I think in capturing now the integrated care system, colleagues will see that it is a fairly low risk at the moment. And I do think that for an organisation such as us, the coming together of the integrated care system and the integrated care board provides more clarity and more certainty, because it operates at such a level. And all the while, when, you know, a number of years ago, when we were commissioned by 5 different clinical commissioning groups, that was far greater a risk in terms of differing points of view, historical commissioning, multiple relationships and opinions. And I think now that the governance architecture is together. Of course, there will be an element of risk of our ability to autonomously state and deliver our strategic ambition, because we will have to do that in a very different partnership way. But so it therefore still needs to be a risk. But I think the exec team and I, and talking to Zoe as well, felt that this was a fairly low scoring risk at this point in time. Of course, as the ICB becomes constituted and the governance structures become live after the 1st of July, we'll be reviewing the impact to SCFT and to the board and to our delivery of our strategic goals at that point. But it feels a more positive move now that it's not a fluid system we're working in. It's one that's starting to become more coherent and tangible. And then, of course, colleagues will know that we've had a various degree and quantum of size of risk related to the COVID-19 pandemic. Delighted to see that be captured as a new risk, so that we're sort of looking a bit more forward, I think, now about the impact of the pandemic on patient care in a more normalised environment. And, you know, interesting to see how high that risk was. Of course, you would expect it to have been up there alongside workforce as our most significant risk a year and 18 months ago. But again, pleased to see that. I think we are capturing that in a way that is realistic, i.e., whilst we're not in a significant wave of the COVID pandemic, we still are looking after patients with COVID in our beds, as are the acute hospital trusts. And in all probability, there is likely, according to the epidemiologists, to be another resurgence of some description as autumn and winter comes, whether that's, you know, the flu pandemic, a flu season, or another version, an iteration, variation of the pandemic. So the reality is that's the world that we are operating in. But again, colleagues will see that fairly low scoring relative to our higher scoring risks. The last thing I'll say is financial sustainability. I know this conversation has been had at in some detail, I understand, at the Resources Committee, and rightly so. We should note that for the first time in a very long time, the financial risk is the highest that we have. And I think that reflects the challenge of delivering on our financial plan this year, with a cost improvement programme that is fairly stretching and is having an impact particularly on our operational teams, our operational leaders, in terms of the challenge of getting back into financial rigour and holding to account on the finances, when for literally 2 years of the pandemic, that's not what we've been asked to do. So it's a very sharp change in conversation, holding to account, and financial due diligence, which is why that one's as high as it is. Other than that, I'm happy to pause, and myself and exec colleagues can take any questions on the BAF.
Leslie.
There's just one for, I suppose, my knowledge. On the BAF risk around cyber resilience, is there a business continuity plan, or are you calling that the resilience plan? Is that one and the same thing?
It's different things.
Yeah.
So the resilience plan is what other activities that we are engaged in to ensure that the likelihood, if we were to be attacked, we'd be able to sustain it, or stay operational. And so it's sort of hardening our defences, and there's a multi-layered approach to that. So that's what the resilience is referring to. Business continuity is a sort of broader corporate thing that we all work on across all of our services, corporate and
that includes the digital element as well.
Elements are in it. So what would we do in the case of its business continuity? So it's more like a if rather than how do we protect ourselves as a separation, I would argue.
Because it feels that's becoming more and more important as more of our services use a digital solution. If that suddenly fails completely, do we have other ways of dealing with things? Kate probably want to come in on.
Yeah, Leslie, I just thought it might be helpful to add that we've got a tabletop exercise coming up, I think it's next month now, to work with services and corporate services and the digital team to look at business continuity around cyber attacks, so that we've got a clearer plan in place.
Excellent.
And I've just final thing to add would be, so there's a kind of a scoring mechanism that the NHS has, which is called Cyber Essentials. We have been previously what they call cyber essentials accredited, and there's a higher level which is cyber essentials plus, brilliant names in the NHS. And we're now on a journey to achieve that. So there's a few things we need to kind of hurdles to get over, but our objective is to try to achieve the highest level of cyber resilience in that accreditation. So a report at some point will come back when we've achieved it over the next few months.
Can I come back with one more?
Yeah, of course you.
Integrated care system. I just wonder whether we ought to recognise the chair's input into the ICS. It's because that's fairly crucial in having another avenue.
Yeah, that's a really good point, Leslie. And I know that there's a chairs forum, I think it's called.
It's got a funny name.
Yeah, but it is the chairs coming together. And I know that Peter and I often in one-to-ones are talking about the various alignment of messaging and various intelligence that we're gathering. So that's a really good point. Yeah, we can add that.
Mark, you want to come in?
Yeah, thanks, Peter, and thanks, Siobhan, for the articulation of the two new risks. So two small questions, really. The first, I think it makes perfect sense to move into a risk around the ICS. I just wondered, given that we're in that transition and things are still developing and bedding down, whether our risk is slightly elevated at this point, given the slight confusions perhaps around some of the decision-making positions and actually getting things through the process. So whilst it's relatively low, I just wonder whether it's slightly elevated now compared to how it may then flow through in the next 6 months or so.
Yeah, it's a good point. I mean, my sense on that, Mark, is that the uncertainty is manifesting itself more in finance and contracts than in the ability for us to deliver on our ambition and deliver on our objectives and our strategic goals. And I think perhaps in the financial risk, we might want to just make sure that we articulate the link back to the uncertainty in financial allocations and contractual positioning at this point. I don't know, Mike, if you would agree with that. I think that the uncertainty, whilst frustrating, is probably not particularly debilitating for us as an exec team or as an organisation, but it is manifesting in ambiguity about service expansions and contracts. So I don't know, Mike, what you think, or whether you think the ICS one we should elevate and do the reverse, mention the money in the ICS one.
I think I've hinted at it, and it's implicit rather than explicit in the finance risk when we're talking about bidding for additional investment, and some of that is still uncertain. So I've kind of talked about it, but I've gone around the houses. I think we could tighten up some of the wording in the finance risk to say, actually, with the immaturity, I guess, of the ICS governance systems, that's leading to delay in decision making at times, which could have an impact on, service delivery. So I think I could capture it in the finance risk.
So being more explicit in the finance risk, Mark, would that capture your point adequately?
Yes, and Siobhan correctly identified where my thinking was. It was very much around some of that financial decision making. So I'm happy if we pick it up in the finance piece. So thank you. The other thing was just a very small point, which was just in terms of the COVID pandemic impact on patient care. I just wonder whether consideration has been given in terms of where the oversight is and whether it should sit in QIC just because it's patient care related. I don't sit on QIC, as you know, I just observe in the papers.
Yeah. I mean, it's a good point. Sorry, I should have said on that one also, and we'll cover this later, that although at the time of writing, we were in a national incident level 4. Soon after this was published, the national incident was de-escalated to level 3. So just for completeness. I don't know, what's your thoughts?
So it's a good challenge, Mark, but I wonder if what we need to do is make sure that the quality and patient experience risk, which is has oversight from QIC, make sure that reflects the current position around COVID and the pandemic, the impact of that. Because my reading of this new risk is this is more about our capacity and our performance around delivery as opposed to the quality of care. And that is already reflected, but we can certainly look again at the quality and patient experience to risk to make sure we've articulated it fully.
I'm very happy for you to just take it away and consider it, because I'll leave it with Leslie and you to consider that approach.
Is the counter, though, that looking at the impact of COVID on patient care needs to encapsulate both operational and risks around quality of service? So we need to make sure we look at both, surely.
Yeah, and actually we discussed this very recently, because we, as I say, we opened this new risk in the kind of light of still being in a national level 4 national incident, and that we needed a COVID risk on the risk register. Actually, the conversations that Claire Turner, myself and Donna have been having is that probably this needs to be encapsulated now in a broader risk around flu, COVID and all the things that Siobhan's kind of referenced. So I think probably, although we've only just opened this one, we may need to consider closing it in the light of the incident reducing and have a broader...
so you may need to think about how you revise it. Yeah. And when you come back with that, what the oversight arrangements are around the revised risk.
Yeah. I think it would be appropriate when it comes to QIC from the Infection Prevention and Control aspect.
Can we list that as an action there?
Thanks, Peter.
Any further comments? David. Sorry, David, I didn't see the yellow line around you.
It's just it goes with the yellow tie. Just a quick question on cyber resilience. We've got a target date in there of 30 June, which is sort of 4 weeks away. Is that realistic?
Diarmaid?
Which one?
Cyber resilience, did you say,
yes.
David?
Yeah,
that's July 25. Yeah, so we're in a situation where we are, as I mentioned, the cyber resilience activity in terms of us being able to remove some of our risks. We expect to have overcome the biggest one by the end of May, which is removing an old server farm. Sorry to go into the technology, but there's a big risk we have, which is getting rid of some old kit, and the plan is to be migrated off by the end of May. Once that's done, then my confidence in reducing our risk level is very high. So that would be something that's going to happen very shortly in terms of that. The only thing that might change it, which is something we've oscillated on a couple of times, you may recall, David, is that if we are getting repeated messages from the National Cybersecurity Centre and all messages coming through to the CEOs of NHS Trust, which has happened, about saying stay elevated, then we might not bring it down again and just push the data out, because we wouldn't want to risk that sort of didn't make sense to what the national picture was looking like. And this is all about the war of Ukraine and the increased numbers of attacks. So there's internal work that says bring it down, and then there's being sensitive to the wider picture that says leave it up, because otherwise you might look like a bit of a fool. So those two things are balancing. So I'm confident we could, but we may not choose to because of the wider scenario. I hope that answers the question.
Yeah, okay. So we'll. I think the message I'm taking is that if we're looking at what we've got in here, the end of June looks realistic insofar as the big risk and the old kit you'll have dealt with, and then I guess when you get to the next version of BAF, it will be whatever the cyber environment looks like at that stage, which I buy. Thank you.
Thanks for that, David, and thanks for that response, Diarmaid. Mike.
I was just going to, I was debating in my head to think when the best time to do a quick update on what's going on with the planning round, which impacts on the finance risk. It probably fits better here than with the IPR discussion. And it was just to say we are being asked to resubmit finance and operational plans system on the 20th of June. At which point we can see where we've got to on this risk. This risk is attached to, as you can read through, some of the uncertainty around our funding. Some of that's around excess inflation, because since the financial sort of envelope for the NHS was set, as we're all aware, inflationary pressures have increased. So there is a chunk sort of publicly known now as £1.5 billion amount of national monies that are available and are being allocated across systems and then down to providers, but it's uncertain and looking increasingly unlikely that would cover all of our excess inflation. But we're working that through, and we should know the answers ahead of the 20th of June, by which time at June board I'll have sort of significantly updated the risk, and we'll see what's crystallised and what risk is remaining.
Leslie.
Can I question in response to that, Mike, because you don't mention in this risk at all the impact of SIPs, and I've read somewhere else that actually, Kate, you reckon that the SIP could be equivalent to 7% this year on your budget. that must be a huge risk in terms of continuing services going, but that doesn't seem to be reflected in this.
So we've got it in the rationale around cost improvement plans at a higher level than it has been for a number of years. And then we've got it back down in the actions, which originally we were hoping to have completed by April, but because of this ongoing planning round.
Maybe it doesn't jump out at me enough,
okay,
because I think that's actually a huge risk for the services.
Again, so I'll think about how we articulate it, because it's in the rationale, but we obviously need to re-emphasise it then. Yeah.
Thank you.
And actually, the answer to the 20th of June will actually sort of be the final. There's a chance that more risk gets pushed to us in terms of if all the inflationary pressure is not covered, which will only increase that, and then we'll decide how we reflect it if that happens within this risk.
Okay. Thanks for that, Mike. Any further questions on the back?
Just one point of accuracy for board colleagues on page 38 of our pack. Just to state that the consequence and likelihood on the ICS risk are the wrong way round. So apologies, but just to note that the likelihood is 2 and consequences 4, and same at target risk.
Well spotted, Siobhan.
I think it's well that.
Thank you for that correction.
Peter, just to add one other slight error on Mike's risk on financial sustainability, the scores of 20 on page 30 should be red, not amber.
Thank you, Mark.
To show
on that note, it's good to know that board members have an eye for detail. On that note, shall we move on to corporate objectives for the coming year, Siobhan?
Yes, thank you. And board colleagues hopefully will be familiar with this set of strategic goals and the corporate objectives. Notwithstanding Mike's point earlier about us, I guess, continually learning on how to capture the right outcomes from the objectives. And I think it's really helpful that board colleagues continue to remind us that we need to be able to articulate the outcomes, because for some it's easier than others to specify that. But I wasn't going to say anything specifically on the detail other than to say obviously the corporate objectives give a clear signal of the areas of priority. Many of the individual personal objectives for the execs also overlap with these. So we're trying to streamline as far as possible a handful of priorities individually and collectively to really drive forward over the forthcoming year. I'll check if Mike wanted to add anything. Otherwise, I think we just open to questions for colleagues.
No, only that we'll formally report at the end of Q1, and we're nearly there, aren't we? But because of that delayed planning round, it's later in the year than we would normally present.
And for the sake of clarity, what we're looking to endorse is the 22-23 objective in the context of our developing strategic goals. Yes,
yeah, good point. So throughout the summer, we'll be testing the draft strategic goals that we've worked up as a board with internal and external stakeholders and patient representative groups to draw in any insights from both colleagues that work for SCFT and people who have a significantly vested interest in the direction of travel for the trust. So yeah, today the ask is to formally approve the corporate objectives, and as Mike said, we can then begin reporting on them.
Any questions from board members? Leslie?
Just to say that they're a vast improvement from where we started, so thank you for all the work.
Yeah, thank you. Yeah, well done, team.
No other comments?
I can't take the credit for that.
I think you can share some of the credit. Okay, so we're happy with these as a means of moving forward. Thank you very much, and thanks to everyone who's been involved in getting these to a good place. And that takes us on to item number 5, with digital strategy. Diarmaid.
Thank you, Chair. So firstly, it's a website, and we accept the fact that that's probably a slightly new way of trying to do a strategy for people like that. So accept the fact that that's warrants a different type of conversation about what we're trying to achieve here. We did a lot of work talking to staff and patients across those organisations to understand what they wanted from digital, and that's a conversation that's ongoing. We continually research our staff and our patients to inform what we can do to support them from the digital team. We very specifically stayed away from doing what classically would be a 5-year plan or a 3-year plan, because, and I think the experience of the last few years has shown amply that things change very quickly in the digital space. And so you lay out too future a plan, you potentially don't give yourself the ability to use the technology at our fingertips to enable the rapid rollout of video consultations and video conferencing being an example that's happened very recently for us as an organisation. So it sets out a series of strong ambitions. It lays out a whole programme of work that have embarked on to meet those ambitions. That's what it's trying to do. And what we're asking for is approval of the ambition and an understanding of the programme of work. The big exam question that would follow, and we would expect it, is the so what question. You know, how is we going to know that this has worked? So we have been working very carefully with the resources committee to develop a strong dashboard to demonstrate the outcomes of the work that we're doing. What normally happens in a digital space is that you count projects. This is a project we started, this is a project that ends. We have just recently, as by way of an example, rolled out EPMA, which is in our first of our wards in Upfield. Now, so you could congratulate the digital team of rolling out EPMA, but you may have made all of our staff really unhappy with the product that they've done, and it may have no impact on the patients as a result of doing it, and it have made no efficiency gain in terms of the way that the services work. So we have been, and have numbers of examples of this, evaluating the rollout of certain work that we do, or the implementation of systems, to demonstrate outcomes, efficiencies, and efficiencies for our staff, patient outcomes, and also efficiencies for the organisation as well. So what we're asking for is to look at the ambitions, understand the programme of work, but ratify it in the context of we will be bringing back continually levels of reporting that demonstrate how we are getting the successes of this, and not just counting the projects or the success of the project. We want to count the success of the outcomes of the project. And there are multiple levels to that, how we might count. So you could go at the really highest level. One of the scoring mechanisms that we discussed we will be reporting at the Resources Committee is our digital maturity as an organisation, and there are metrics by which you can score a whole NHS trust. And an example of delivering EPMA is that ticks the box as being one of the elements to get a higher digital maturity score. But again, I wouldn't want to just do deliver EPMA, count the score. I'd want to demonstrate, as we've already seen anecdotally in the EPMA rollout, that it's increasing the amount of time that staff have on the wards to do their work. That's a much better thing for us to track. So you go down from the highest level of reporting for something like our maturity, all the way down to how many miles have our community nurses not had to pay for in terms of driving around the county. And so we're looking at dashboards that demonstrate the outcomes, the effectiveness. So what we're asking for is to approve the strategy in the context of dashboards and complex reporting back on the effectiveness of what we've been doing in the delivery of the outcomes of this organisation. And I understand that's a shift from doing a sort of classic strategy, which would have milestones of project deliveries as an alternative way of measuring it. So that's the context that I wanted to provide.
Okay. Thank you for that, Diarmaid. Now, I know Resources Committee had discussion about looking at key milestones and the oversight of a delivery plan. And I wonder, Mark, as chair of the Resources Committee, if I could bring you in first in terms of your perspective of this development.
Yeah, sure, Peter, thank you. And I think it's fair to say we've had a number of conversations over several months around the digital strategy. And I think we've, as Dermot said, we understand the broad intent, which are the 6 themes that have been outlined, and also recognise it's a dynamic approach. So the challenge that we were wrestling with is, given that fluidity, how do we ensure that we understand that we're doing the things we say that we want to do, and actually they make a difference. And we probably, as Dermot says, I think the digital performance dashboard will be a key element of us understanding the progress that we're making in this space. And I sort of viewed it under 3 levels. The first was that top level organisational digital maturity, which there are specific mechanisms that you can use to track it. The key thing is really what Dermot was talking around outcomes and effectiveness. I mean, as an example, we said, okay, great, we implement a new app. So what? So we want to understand the adoption of that new app, feedback around ease of use, what difference does it make for patients or staff, and then what value does it create for the organisation around, efficiencies, time, costs, whatever. And that's what we're working with Dermot on to make sure we bring back regularly to the committee. And then just for the board's awareness, I guess the other thing that we're very mindful of is, getting the basics right. So the underlying cybersecurity, risk management, data management, access to systems. We recognise the importance of that. So that would be the sort of the third thing that we're looking at. So my sense, Peter, is through Resources Committee, and we've got quite a challenge here because this is a new way of operating, but I think we have the intent to say we recognise what you're trying to achieve. There is a plan, and what we're trying to make sure we do is understand the difference that the digital activity is making across the organisation, both for patients and for staff. And then the only other thing I was just going to add is we've been very successful, or Dermot's been very successful with the team in gaining funding from external sources around Digital Aspirant and Digital Aspirant Plus. So we also recognise the need to make sure that we can demonstrate that we're meeting those obligations in terms of external reporting and the approach we take. So I think there's an additional thread that we will need to look at in resources to ensure that we can show that we've used the money appropriately and wisely. So I'll pause there.
Okay, thanks, Mark. And on that last point, I was going to raise this because there is an external element to our digital ambition, isn't there? Which is not obviously completely within our gift in terms of we're working with national bodies. Would you just say a bit about that, Dermot, and how it fits in with the overall shape of things?
I'd connect it back to what Siobhan was mentioning in terms of our corporate objectives. So we are being asked to be a digital leader, as a community digital leader, as a trust. We're being asked to demonstrate new natures of relationships with our suppliers. And to me, the EPMA, again, as an example, that's the first time I has delivered an EPMA project. It's the first time they've integrated with a third party to make that a closed loop EPMA system, which is groundbreaking. So there is a big ask on us from national. The quid pro quo of the money is demonstrate to the rest of the world that you can do things differently and move the dial. And so we have to demonstrate, and the website and its external articulation of what we're doing is a part of our play back to to other organisations in the wider NHS world. This is what we're doing. This is how it's working. So that in a nutshell is the requirement, which is to demonstrate the impact and the effect. And we don't want to, which is again goes back to the complexity that Mark's alluded to. If we just say we've delivered EPMA, we've delivered ERS, or all the acronyms the NHS sort of score, then we would fall into the trap of not demonstrating the outcomes and the benefits, and I think we would fail at being asked to be a digital leader in that context. So that's bar is set intentionally to speak more broadly than just congratulating yourself on lists of acronyms. So I get blunt about it, but you see my
we want to do more than deliver an acronym. We want to deliver some benefit. Absolutely. Other comments than what you've heard? Giles?
I think if the question here is looking for the board to endorse the ambition, the points I'd probably make, Peter, are whether it's a reflection on me or them. I've worked with a lot of directors of IT, and rarely have I found one as impressive as Dermot, with the ability to talk about servers in a way at one end of the spectrum and patient delivery at the other is quite something to be able to get your head around, and quite a rare thing. I think I've only met one other person who's done it, but equally to understand staff experience and what on earth is happening at the centre in London as well, I think is quite something. So I think that's the starting point, is this organisation has a huge asset in what is brought to bear there. I think the other bit around it is just that bit stage further around the we've brought in EPMA, we've done this. If it doesn't work, do we then take it out again? And I think the other bit that's impressive around this, it isn't just about servers, widgets and screens, but it's actually about trying to move the people within the organisation. And I think that's one of the biggest challenges sometimes, is getting people to change the way that they do things. And some of the indicators that come through, whether it's miles driven, I'm sure you could tell me who uses the most paper in the organisation. It's not an issue in itself, but it just kind of is an indicator of, are we drifting in the right direction here? And so I think this is an exciting and ambitious plan. I think the outcomes and the foundation of it are well placed. And I think the resourcing around it is incredibly reassuring as a board, because it doesn't rely on everything coming from within. And the breadth and consideration across it is significant. I do think that there is always going to be the gaps of how much information do we or don't we not want. And Dermot will always be subject to, you've told us too much or you've told us too little. You can get a strategy on a postage stamp or a duvet in this world. and it's just finding that right balance for the right audience at different times, which you can guarantee to not have satisfied somebody in the room every single time you speak. But if it's about endorsing the ambition and the approach, I think this is a very impressive ambition and approach.
Okay, thank you for that, Giles. Any further comments? Okay, so what as a board we're saying is we approve the ambition and intent of the strategy and the 6 key themes that you've laid out. We'll be looking to Resources Committee regards oversight on milestones and delivery, and the development of the digital performance dashboard, which I know you're working on, taking into account the 3 areas you mentioned, Mark, but also acknowledging there's an external element to this strategy, which we have to be cognizant of. Okay.
Yep, thanks, Peter.
Anything further? So thanks, Dan, and well done for getting us this far. Let's now move on to the integrated performance report. Mike.
Thank you. If I just quickly refer to the previous board action, because in this report, although some of the board members will be familiar, the first time we've seen this version of the report in public. So there was a discussion previously about increasing the amount of trends data. We've now incorporated some new sort of exception reporting, and that's the category of where one of the metrics we can't get the assurance looking at the trend that we will consistently hit the target, and that brings a richer amount of explanation to the metrics to enable us to importantly not just be assured where we may hit a metric in month, because if our systems and processes don't allow us to consistently hit the target, we should be aware of that. And actually, because what that's saying to us is we should expect to miss the target as well as hit it. And if it's a target that's important to us, that's a consideration that we need to think about. So that's expanded the amount of exceptions. And you can see that, for instance, in the quality report this time, where there are no in sort of month performance exceptions, but there are a number of categories where we are not assured we'll consistently hit the target. The other thing to note, as we said we would draw attention to, we do in the operational section have a risk over 15 around the North Podiatry Service that Kate will explain. And apart from that, to note that it's always work in progress. We will continue to improve the IPR and wish to do so, not in a sort of revolution, so people can't track where we've come from, but in that continual improvement spirit. So with that in mind, and unless there are any questions just on the format of the report, I'd like to hand over really and move to the first section, which is quality and donors.
Thank you. So just following on from Mike's introduction, you'll note that there are no exceptions this month, but there are 2 areas where we've identified that we may not consistently deliver against our target. So one is patient safety incidents causing moderate harm or above, and the second one is complaints responded to in time. And we've looked at both of these before in board meetings. The report that was very lightly referenced as part of our actions from last month's board meeting is a report that goes to the Quality Improvement Committee, and that shows the committee the breadth of the incidents. It includes thematic analysis of those incidents and gives assurance that there is scrutiny and there is analysis of those incidents, so that we do monitor the number of incidents with harm, but within the context of other factors as well. And we will continue to do that. And in the Spotlight report, which I'll come to in a minute, you'll see some of the work that we're doing to continue to improve and strengthen the triangulation of our quality metrics. The complaints metric, as I said, no exceptions in March, but the overall year shows a high compliance with the target. And we've spoken in previous meetings about the relatively small number of complaints and therefore the impact on the metric for that. And we've also spoken about why some complaints do take a slightly longer time, just normally to do with complexity of the complaint, or the complaint moving into a complaint that needs a multi-agency response. And I've also given assurance again in previous board meetings that we do keep the complainant fully informed of any change in the response time. Shall I just pause there just for a minute in case there are any questions, and then I'll move on to the spotlight report?
Any questions on the exceptions?
Could I just point out one thing on the metrics? We report hand hygiene compliance, but QIC also sees the number of teams who have submitted audits, and that is actually really quite low. So although it's high compliance for those who have reported, there's a substantial number of teams who haven't, both in the community and inpatient units. So that's something that we raised at QIC, and Donna's going to follow up and put pressure on those teams. So we will be looking to see that figure. But I think the board should be aware that this is only a partial response.
And we need to look at that other metric as well.
Yeah, which we do see through QIC, but we'll report that back.
Okay. Thanks for that, Leslie. Any further comments? No? Want to take us on to the spotlight?
Yeah, so two parts to the spotlight report. So I've given you an infection prevention and control update as usual, and you'll see if you try and compare this report to last month's report, it is significantly different, and we really are getting to a much more stable position around our outbreaks. So the outbreak that's here in the report has now formally closed. We have, however, opened another outbreak a few days ago, 6 patients involved in that one outbreak, and that's again stable, no staff involved in that, and like I say, just 6 patients. The IPC risk is now being managed. It's not fully mitigated, but it is being managed, and that's partly because of the system working that's taking place, and that sharing of information and agreeing of standards and approach to guidance across all of our system partners, but also because of the recent recruitment to our Deputy Director for Infection Prevention and Control, who's been here for 3 weeks now and is already making an impact. So we're delighted to have her. I'm very delighted to have her, I have to say. And then the second part of the spotlight report is just around patient safety. So we've just given an example of some of the work that we're doing to strengthen the triangulation of quality information with our safer staffing information. And on that second chart, you can see the tables that the performance team are putting together, which we look at both the Trust-wide Governance meeting and at the Quality Improvement Committee, so that we can actually do some comparison around units that have some risks around their staffing levels and units who have some adverse quality metrics. So it's just to let you know that's the kind of development that we're trying to do around how we analyse our data. And then the first chart, so it's slightly in the other order, the first chart is again an example of we're using Pareto charts to analyse the patient safety data, so we can really focus on what they call the critical few, and then we will be able to target our interventions to have the greatest impact. So those are 2 tools really that we're using to try and strengthen our analysis and provide further assurance to the Quality Improvement Committee and the board around patient safety.
Thanks, Donna. Any questions? Good. No?
Good.
Yeah, we're all very clear on that. And
Lovely.
That sounds like a particularly good development of patient safety. We triangulate. Okay, if there's no questions, we'll go on to operational performance.
Thanks, Peter. I'll just pull out the key points from some of these exceptions. So the first chart around average length of stay, you'll see I've noted before that average length of stay is increasing and predominantly impacted by the impact of patients who are delayed within our beds waiting for onwards care, and also patients in our beds who are waiting for our own responsive services to be able to be discharged, and the impact of delays within responsive services, which has a knock-on impact on us being able to accept patients into that service. Probably just to note, there's much more of a both regional and national focus at the moment on discharge and flow, again, in terms of making improvements, and particularly across the Sussex system. So we're engaged at the moment in fortnightly meetings with the regional team who are sharing best practice, providing support, and we're looking at a series of actions, both things that we can do internally and also how we work across the system to improve some of these measures. And we've also got the internal project focusing on beds optimisation, which will help us look at things like improving levels of discharges at weekends in comparison to weekdays, etc. So I can continue to provide updates on that position. With regards to diagnostic weights, there's no change really in terms of the issue. So the issue is around ultrasound scanning. You'll see that that's an improving picture, and particularly in Bognor, where they've got the second ultrasound room now fully functional. And actually, when we look at the data subsequent to this report in March, that is a continuing improving position. What I'd like to flag there is the deteriorating position at Lewis, and that's mainly related to staffing difficulties, again, which I've highlighted at board before. So that's a deteriorating position, and we have noted with the data again subsequent to this report that it is indeed deteriorating. There's some work around securing agency staff to support us with that, and the team are currently reviewing what that means for their trajectory for improvement, but it does look like I will be reporting a deteriorating position in both April and May. Moving on to RTT, you'll note this month, going back to what Mike said, we've actually broken down RTT this month into the component services so that you can see where the most significant issues are. If we look at those specific services, again, MSK is a service that I've flagged before. That is still causing us concerns in terms of being able to meet demand and clear the backlog, and both waiting list numbers and breaches have increased. We have made some changes within that service more recently to bring the, in particular, the physio appointment times in line with other providers. They were quite long, the appointments that we allocated to patients for physio contacts. So our clinical leads have been working with the team to bring that appointment time down, which should mean that we can increase capacity and hopefully make quicker progress towards meeting that trajectory. You'll note also, just going back to Siobhan's point about the waiting list corporate objective, that there's more information in this report now specifically around longest wait times and median wait times for patients, which I won't go through in detail, but happy to take questions on. I won't talk about chronic pain and rheumatology because there's little change there. And again, with our child development centres, I flagged before that we've got issues with capacity and demand at Crawley CDC, which continues to be an issue for us. We're still planning to meet the target in September, but that's through bringing in additional capacity. And we know that without that additional capacity, we won't be able to meet demand in the longer term. Dental, I'll skip over because the Spotlight report focuses on dental services this month. So I can talk a bit more about dental services there. And I wasn't planning to pull out anything in particular from the additional exception reports, except to say that the new birth visit for Brighton and Hove Healthy Child programme has performance has returned to target for that service. Should I just pause there before I move on to the Spotlight report?
Yes. Before I put it up, a couple of things from me. At the bottom of page 67, Kate, when you're talking about referral to treatment, you say that action plans, some of which are dependent on the continuation of external funding. Can you tell us anything about that?
Yeah, so for instance, the MSK service is currently got additional capacity because of national funding that's come in there to clear the backlogs. And CDCs in particular, if we don't, if longer term, we know that we need, the referrals have gone up and we're going to need secured, sustained longer term funding in CDCs. So those are the kinds of things that will impact on our ability to.
And that sounds potentially like quite a significant impact if that resource isn't available.
Yes.
And you sort of got into my second question. Do we think the capacity issues in CDC, do they look like they're going to be medium to long term, or is that just a flip?
Yeah, no, we think those are going to be medium to long term. So members will be aware of the issues that we've got, particularly in the neurodevelopmental pathway. We're already seeing an increase in referrals prior to the pandemic, and we're seeing a significant impact across children's services, actually, of the impact of the pandemic, and particularly in some cases where services where the national guidance was to pause or suspend services, and the sort of longer term impact is well known now, really, in terms of impacts on children and families. So yeah, we don't think that's going to change.
Not going to go away.
No.
Okay, thanks for that. Questions for Kate. Leslie.
I'm sorry, Kate, I'm going to sound like a broken record, but looked after children. I mean, these are some of the most vulnerable children in our care, and yet the performance, although we celebrated the fact it hit the target last time, actually is coming back down again, and it's up and down. I suppose the question is, what are you going to do to try and get it on an even keel? And I absolutely recognise the fluctuating numbers of children and some of the problems you've already discussed with community paediatricians. But we feels like we, as a board, we have to do something different.
Yeah, so we have recognised exactly the same, Leslie, in terms of the fluctuating performance against this. And you're right, these are some of the most vulnerable children, and they need to receive the service that they need to receive. There's a couple of issues around this. As you said, the fluctuating demand does make it difficult to plan for capacity. What we have agreed with the service now is that we will plan for peak demand. And therefore that may result in some redundant kind of capacity, but that's probably better than not having the capacity available at the time we need to see these children and young people. So the service are working through that plan at the moment. You're right, there is a kind of link with the neurodevelopmental pathway, because we're relying on a small number of paediatricians to be able to respond to both the long backlogs in the neurodevelopmental pathway and being able to see these children. And the national guidance around initial health assessments means that we can't use, there's no flexibility in terms of what staff group you use to deliver the assessment. So we have to use community paediatricians. Having said that, as I said, we'll amend plans so that the capacity is there to meet the height of demand.
So can the board have assurance that the other targets around looked after children being met, because there's an annual review, isn't there? So that is being met.
So the other targets are met, and that's because it doesn't use the same staff group. So annual assessments are carried out by the nursing team, and they are met. Yeah.
But I just have one more, and thank you.
There's no ration.
No ration. I just wanted to point out the time to talk, because you mentioned around outcomes, that I went on a visit to the service, and it's not only the outcomes are good, actually the outcomes are brilliant. They're top in the country over all the outcomes. And I just think we need to recognise that as a really good outcome for the service.
Yeah, thank you.
Let's make sure the minutes know that it's a very good service. Charles?
It's just around the differential between the performance, I think particularly around the CDC and the neurodevelopment pathway between Crawley and the other two, and whether there's any scope and whether we're limited in the way that we're currently commissioned of moving either the patients or the resource across the group so we get a more even performance across all three, or whether, and that'll become an opportunity if we can move to the ICB, or whether it's just a non-starter because of the way the service is delivered.
No, we have looked at for both, actually. So the neurodevelopmental pathway is a big piece of work ongoing at the moment, and a plan in place to make changes to that pathway so that we can do exactly what you've described and make sure that that's evened out across services, and using different skill mix and to deliver that so that we can make improvements in that pathway. The looked after children, there is the potential there's a potential to move staff between centres, but that's increasingly difficult with a very small pool of staff. There is always the potential for children and their carers to travel further, and we do try to offer that where we can. There's obviously an impact on families from asking them to travel further to an appointment. But we have had discussions previously about whether we look to centralise these assessments in one or two centres across the county so that you improve efficiency and capacity. And I think those are ongoing conversations across the system, really, as to what the impact on families would be, but whether that makes more sense in terms of service delivery.
I guess if you take their perspective entirely, it's whether you give them the choice of
yeah.
will be seen here in 6 months, or we can see you here in 1 month, which do you want?
And of course, the problem with the initial health assessments is that there's a statutory target around there, so that becomes more difficult in terms of delaying patients who would rather be seen in their local centre. But all of those conversations are ongoing.
Thank you, Kate.
Thanks, Kate. Any further questions for Kate? No. Okay, you want to take us on to
I'll hop to the Spotlight report. So the Spotlight report of this month is around dental services. And really, this is a good news story in terms of the progress that our dental services have been able to make to address backlogs in care, which were caused predominantly by services, again, in line with national guidance, stopping during the pandemic. So I'll just kind of pull out some of the key points. So you'll all be aware that the biggest impact was on patients who were waiting for general anaesthetic interventions, and the initial timeline that the service had set for recovery was January 23 to be compliant with the 18-week target. You'll see there some of the actions that the service have taken to move that forward, and actually they've managed to recover that position 7 months ahead of schedule, with only 5 patients at the time of writing the report who were breaching 18 weeks, all of whom had appointments booked. The second kind of half of this slide just shows what the current pressures and challenges are. So the team is still experiencing some impact of COVID sickness in particular, with either patients not being able to attend their appointments or staff shortages caused by sickness. And you'll see that the issue with patients who can't come for a GA appointment is that it's 7 weeks before they can be offered a new appointment. So that's continuing to impact on the service. The other thing that is increasingly impacting is the availability of general dental services within the community. So you'll see there that in Sussex, 4 contracts were terminated in 21-22. There's a further 5 imminent, and there's been 3 contract reductions. So the amount of patients who need to be seen through our services because they can't be seen in general dental services is increasing, which is impacting again on the service. This team have looked really closely actually at how they move staff around to meet the kind of fluctuations across the county. And the Parol, who many of you will know, the clinical lead of that service, she offers additional clinics in areas where there is increased demand or increased need. I'll pause for any questions.
A couple of things, Kate. I suppose the first thing to acknowledge is this is very impressive.
Very impressive.
The second thing is we, as an organisation, of course, when things go wrong, we investigate. Well, there's an example of something that's gone really well. Are we giving it the same rigour in terms of working out whether some of this is transferable to other challenges we have?
Yes, I think it's a really good point, Peter, and certainly it's something that I talk about with my team in terms of how we can share learning, but it might be something that we need to formalise a bit more in terms of sharing learning. I might talk to Donna about that, and in terms of
QI approach.
Yeah, QI approach, yeah, exactly.
Because then, my guess is there's an awful lot for us to take out of this that we can use in the organisation. We shouldn't lose that.
Yeah, that's a good point.
The questions.
GDS contract. Have we considered as an organisation taking on some of the GDS contracts?
No.
I mean, I was just dropping it in.
It's a good question because, of course, the delegation of commissioning of general dental services is moving from the central NHS England function to ICBs. So pharmacy, optometry and dental services, high street services are all coming much closer to us through that move. And I know the Sussex ICB, when it's constituted, has already applied to be one of the early runners in receiving that. There's a process nationally to go through. So it's an interesting dilemma for us. It isn't on our near-term radar, but I think once that commissioning becomes a much more localised function at our Sussex ICB, it may well be a partnership opportunity or an opportunity to do things differently.
Crawley as well.
Sorry?
Spare room in Crawley.
I mean, this is we should, as Kate has said, this is an exemplar service run. I was chatting to some chief executives around the country about care backlogs in community services, and at least half of that group were really concerned about their special care dentistry service as a number one above neurodevelopmental pathways for children. So your points are well made. We should learn from the methodology and the leadership that this team have from within, but B, consider whether our expertise in this space can add value in contracts that aren't currently within our gifts. But I do think that national move out of specialised commissioning into integrated care boards for the commissioning of general dental services is going to be interesting.
Thanks for that, Siobhan. Mark, you want to come in?
Yeah, well, actually, the point I was going to make was to reinforce that which others have said, which is this is a very impressive achievement given the fairly bleak picture that was painted some months ago. So absolutely concur with the congratulations to the team, and also making sure we take the opportunity to see where we can learn and duplicate this success, because it really is very impressive. The other point, again, has been touched on, which was I recognise there's a real challenge around capacity in general dentistry. And so I'm just wondering, if ultimately it just will increase the pressure on this service as people can't get to dentists and conditions are exacerbated, what, if anything, we can do, notwithstanding we may not wish to take on the general dentistry, but what can we do within the system to flag this, because ultimately we'll be at the back end of the challenge, I guess.
We need to do as much as we can to raise the broader issue, don't we?
Yeah, and I think when we get into the sort of more normalised contractual discussions with ICB colleagues, that possibly is something for us to raise in the coming months, which is, this is a well-performing service. However, demand is increasing as a direct result of the GDS challenges. What can collectively, as you say, Mark, collectively as a system, what can we do differently to meet that surge of demand, which is well publicised through the media at the moment as well, that, there is simply not enough capacity to meet the demand for NHS dentistry in particular. So I think it's one for us to raise with ICB colleagues in the coming months, Mark, once we get the infrastructure landed around contractual discussions.
Thanks, Siobhan.
And please pass on our...
I will do. Yeah, I certainly will do.
Okay, anything else for Kate? In which case, we shall look to Caroline to tell us about workforce.
Thank you.
It's very good. I was just going to say whether Kate wanted to talk about the operational risk.
I do.
Oh, of course.
Sorry, thanks.
You mentioned it early on, but we didn't follow it up.
Just gloss over that one. Yes. So we've got a risk, an operational risk 15 and above in the Podiatry North service. And this is predominantly related to staff availability. You can see there the national shortage of podiatrists, and we've got high turnover, vacancy and staff absence, and also a significant increase in high-risk referrals onto the caseload. I won't go through the detail of the control measures and the actions, you can see them there, but just to sort of add in the short term, the service have now completed a risk matrix, which has been agreed in principle, and Donna's supported the team to do that. Currently in the process of writing to all the impacted patients, and that will mostly be those who are in the low risk category, and signposting them to other services. The learning disability team are supporting learning disability patients within this pathway, and we've increased nurse capacity to assist the team with sort of managing risk, and in particular the tissue viability nurses are supporting the team, which historically, so that's different from how we've historically delivered the service. In the medium term, we know that we need to review the service level agreements we've got in place with other providers in terms of what we deliver to them and whether that's sustainable in the longer term, and also to review the service specification in light of the sort of increasing higher risk patients and how the lower risk patients who we may not be able to see longer term, how they will receive services. Happy to take questions on that.
Kate, this is not the first time podiatry has risen up the risk register. It sounds like a slightly different issue.
Yes, so we've had issues before around risk in podiatry associated with staffing. That's a sort of ongoing and, as I say, nationally reflected issue. This is slightly different in terms of the quantum of those low risk patients that are impacted this time.
And the changing pattern of services, yes, and more specialist cases.
Yeah. And again, that sort of reflects the changing pattern across a number of services in terms of complexity and acuity of patients that are coming through. But it's significantly impacting on the Podiatry North service at the moment.
Any questions on the 15+ risk? No?
Thanks for that, Kate, and thank you, Mike, for correcting my oversight. And try again, Joey. Caroline.
So 3 things to note on the report, really. The first is just to say that the turnover rate as a monthly figure will hopefully be from next month. So we've talked about how unhelpful it is to have an annualised turnover rate. So we're working on that at the moment with the performance team and the workforce information team. So hopefully from next month we'll be able to have a bit more of a discussion around that. The second thing I wanted to say is that there has been some, although not automatically reflected in our data, there has been some improvement in our sickness absence, and in particular a reduction in long-term cases that are lasting 6 months and over, and also on the what we have described to the board before around high impact absences. So those are absences where people may have intermittent absence but that are recurring often and therefore are having more of an impact on the service. So these are good progression. I think if I can name a couple of people, the occupational health project, which we've been running for a few months, has been incredibly supported and led by Richard West from Mike's performance team, Mike's partnership team, and Julia McTaggart from the QI team and the QI team themselves. And they shared with us yesterday all the work that they had done, and I think that project, and Donna was there, will I'm sure back me up on this. I think when we start taking the actions we need to take to improve the service, that will have an impact on our sickness absence. We definitely have done a great job on that, and if anybody has any questions, I'll happily take some, or Donna. But it was just to recognise those 2 people, because I think they've been incredibly helpful in helping us unravel what was going on in the service, and we've done a really great QI project on this, so it's great. And then the third point I wanted to raise was on the Spotlight report, the Wellbeing Fund, I read this morning on my way in a tweet from somebody called Helen Morrison, who's the team lead in RNPCN, and she said the team applied for funding for plants in her office, and she said the plants are great and will make such a difference to the office space, especially nice for our reflection room. We are so lucky to work for a trust that really cares about our well-being. So it might sound simple to have a bit of money to buy plants, but the impact on frontline teams is being shared, and I know there are some examples of feedback, but this one was hot off the press this morning on Twitter, so I thought I'd share it with the board. So happy to take any questions from any aspects of the report.
Dipesh.
Yeah, thank you for that. In respect to the turnover, you mentioned that you're looking to identify factors contributing to it and the employee experiences. So I know that's ongoing, but given that it's been increasing month on month, has that started, and is there anything that's been learned from that?
I mean, I think this is the issue with the annualised turnover, and Mike's going to help me with this if I get into the detail of the maths and can't quite make it clear. But the increase in the turnover rate was experienced in autumn last year. But because it's an annualised data, even if things are improving, which they are months and months, the annualisation of
takes a while for it to show.
It's a rolling 12 month, which is a national measure. The problem with a rolling 12 month, as you'll appreciate in a trend line, is actually for a while the 12 month was incorporating where our turnover had gone up, but actually some really good low months in the pandemic. As we shift on, the good months are all disappearing. So even though we might improve month on month, the average is going up still, because we're losing, as you can see in the chart, the kind of low months between Jan 21 onwards are all kind of disappearing out of that 12-month data range. What that tells us really is we need a different metric. The annual one we need to know about because it's a national comparator, but we need a more sensitive metric about what's happening month on month. The reason it's annualised is it is susceptible to in-month fluctuations, but if we're aware of that, we could then look at the month-on-month in an SPC chart and understand those fluctuations are normal and expected variation, or whether they were way outside the variation range. So we will review that and look at a good metric to go alongside this.
So if you don't take the monthly rate and you annualise it for a year, you go back. It's back 1 year.
It's
Yes.
a 12-month
Yeah.
average,
Yeah.
basically.
And so what we want to, one of the other measures we've been looking at is the net variation per month in staff groups. So how many starters and leavers do we have in nursing and AHPs, for example, because that gives you an indication of what your net increase or net decrease is over the year. And we're looking at that workforce committee. So we need to have that information so that you know whether or not we're improving our position or whether we're not. And unfortunately, the annualised turnover doesn't do that. So thank you, Mike, for explaining. Thank goodness Mike is here. One day I'm going to have a question, Mike's not going to be here. I'm not going to be able to answer it.
Recorded.
It's teamwork.
Record now. Kate, you want to come in?
I just wanted to provide some assurance about actions just in relation to your question, Depesh, which is that operationally the areas review their turnover rates in detail. And so where there are teams where we know there's an increase in turnover rate or there's a particular issue, the HR business partners will work with those services to make sure that actions are in train. So it's not that the kind of annualised turnover rate is sort of masking at a more detailed level what's going on. The teams have got that data.
Thank you. I had a sort of related question, Caroline. At the bottom of page 78, you say that flexible working has been raised as a theme, contributing to staff members' choices about whether to stay in SCFT. And you say that Workforce Committee is looking at this. But I just wondered if you could say a bit more about that. Is the indications we're not offering enough options, or what's the intelligence you're picking up?
Yeah, so the deep dive will be in July Workforce Committee, so I can give a bit more information after that. But so there's a number of things. I think we have a way of working which is quite set in a lot of services, and we've been working in the same way forever. So for some teams, the kind of self-management of rotas and things like that is quite well established, and some teams are very good at kind of looking at who might be able to work on certain days and certain hours. I think for some teams that's more of a challenge because there is a clinical workload and there are patterns, there are shift patterns, and we can't just accommodate everybody, but there is a balance of being able to accommodate some people and maybe getting ourselves out of the thinking that in order for us, so for example, this organisation had a rule a few years ago that you could work no less than 3 days per week. We have no idea where that came from. It just appeared one day. And these are things where you just don't know, you can't work less than 15 hours, but we've got twilight services that work on 4-hour patterns. So they can never, so it makes no sense. So there are things that we need to change. And the idea is of the deep dive and the workshop we're going to have in July is really to look at agile working in the context of the estate strategy, looking at operational services and what would be helpful to them, and similarly around clinicians, what would be helpful for clinical teams to be able to think differently. And it's just giving permission to people to say it's okay to work differently. So I don't think we're on our own on this. I think the NHS has been working like this for such a long time. It's difficult for us to think differently, but we're getting there.
What you're saying, what I pick up from that, is it's not our policy that we need to look at. It's how we implement that policy in areas which have had a more traditional approach.
Yes, that's a good way to say it, yeah.
Okay. Any other questions for Caroline? Anything on the Spotlight report? Anyone want to comment on that? Is the fund big enough? That was my comment. I know you've increased it recently. Yeah,
I mean, most of the charity has a healthy budget, and we're able to complement the fund with the charity funding. I think we're okay. It did get too small, which is why the partnership with the charity was absolutely essential. If we didn't have the charity funding, then I think we would look at whether or not that money is sufficient.
Thank you. Charles.
It was back onto the previous one. I was kind of assimilating Caroline's answer to the question you asked, and I think there is something around the environment is set by this board to allow people to look to do things differently and how we do it. I think it's about how we set it against risk. I don't want to look at you, Donna, but it's often the clinical the clinical risk but it's your role. It's kind of the clinical risk of what that means is often one of the things that's assessed there, and says how do we try it and how do we say actually it isn't safe or it is safe, and we're able to push that forward. So there's something about a risk appetite that exists within that, especially when we look to the recruitment piece, because we're trying to be a growing organisation, and yet still I think we have a very internal focus, or we go to the same places time and time again in order to be able to find things. And this came out in a meeting just earlier this week of here's the list of the places we've advertised, and it's kind of all the places where everybody else advertises. And yet some people are finding their jobs through Twitter, and it is the places that people will go if they're looking for a job, as opposed to going to find people who aren't necessarily looking for a job. And how do you find them? And so that there's just something about how we do things that little bit differently, and looking for different people, I think is again one of the challenges. And I know that Gronny, who's online, has sent me a couple of emails around how do we recruit from different population groups as well, to be able to reflect and understand our communities better too within that. And there's something about the engaging at the earlier stage around developing and making people identify this as a career for themselves in the future, and the power of when you talk to people about why do they work here, it's because somebody came into the sixth form college, somebody came into this, and this is what was done. So that kind of slight outreach bit is really important. I think in summary, I think, yes, it's about doing things differently. Yes, it's about doing it within an understood risk appetite. And absolutely, it's about not doing what we've always done or doing what everybody else is doing if we want to create that difference.
But the first point you mentioned there, which I think is something we need to make sure we continue to focus on, and that is how do we give our people the confidence to try new ways of working and different things. And that seems to be at the nub of some of what you're...
And I think it kind of comes back into the policy of, yeah, but the policy says this, and nobody knows why. But it's how do you change that policy? How do you make the policy changing on the fly really helpful? And so it's things like sometimes annual leave policies or career break will hugely benefit the employee, and it stuffs us every single time. The ability to be able to say, no, you really can't take whatever thing sabbatical over 6 weeks of the summer, because that's when everybody else is off. Just delay it by 6 weeks or whatever else. And there's just these policies and the balance in them, and understanding why did everybody ever build this fence in the first place?
That's a good point. And we need to make sure that those policies enable people to do things rather than constrain as well. Okay, on that basis, shall we move on to talk about finance?
Thank you. The IME surplus is a consistent exception. But the thing to note is there's a month 12 position. We were slightly favourable to plan, even though this is adverse variance. That's because of the length of time on the time series, and that the plan was set at a lower level than previous plans. So it's a good news story, although it's adverse variance. So I'd like to note the fact that we slightly overachieved on our plan and hit a 211k control total surplus. On better payments for our creditors, our suppliers, it's great and heartwarming actually, because some of these are local suppliers as well as national suppliers that in month we exceeded the target. So that's great and shows it's possible. So we do know that there are extra focus that goes onto this because of year end, and whether that's so we continue to work with suppliers, because that extra focus, say from our budget holders, probably isn't sustainable month on month on month, sort of year end frenzy, for want of a better way of putting it. But we continue to work with those suppliers to make sure that information comes to us in a timely way and a user friendly way, so that we can sign off invoices quickly. So good news, heading in the right direction. The biggest thing to talk about in terms of the exceptions is agency. As you can see, continue to rise. There are well-known reasons for this. Some of them actually positive in terms of at the back end of last financial year, lots of additional funding to reduce waiting lists. We were explicit in the fact with commissioners and others that the way we were going to do that was going to have to be agency in some of those schemes, just because of
workforce supply and the short-term measure of the money. And so this was a planned agency spend for some of these increases. We've had a good discussion in Resources Committee that says, aside from that, there are other areas where we've got long-standing vacancies and challenges in recruitment. And so there's an action plan that Kate's leading that's been put together. We are looking at really, this is the shift from last year to this year. So last year, people were giving us money to spend on agency, move into this year, and it's a different story. We've got constrained finances, and we are reinforcing, I'd say, rather than reinstating our agency controls across the trust, making sure those controls are robust and are consistently applied. And then Kate's leading deep dives into certain units which are higher spending, and a couple that are well performing to share best practice across and understand the nuances in those individual areas. So that's ongoing. We'll monitor it through Resources Committee. Then in terms of the Spotlight report, really pleased to say that the finance team has become the first team in the south of England to get level 3 accreditation for future focused finance. So this isn't just a self-assessment. We have to pull together a huge amount of evidence, and then we are externally assessed against the criteria. And it's across the board in terms of our reach into the organisation, our reach into the system, and actually how we develop talent and support the team as well. So it's not an easy thing to do. The team have been fantastic in putting together work and pushing work forward, because we had level 1 a few years ago. We moved to level 2, and this all has been going on during a pandemic. So it's very noteworthy, and there's some great people in the team pushing forward, especially around Jamie Buick and Tim Blatt have been key in delivering pieces of this work. So the bit they were really pleased with was how we support staff and bring them through. So whether that's apprenticeships, whether that's training while people are in the team, but the assessors were really impressed with that work that's going on in the team. And then lastly, a note on the payroll service provision. We are part of a Sussex-wide piece to re-procure payroll services. That goes sort of both ways, I guess. It's great because we get the scale and purchase, and I think this is absolutely the right thing to do, and we've been in conversation with Resources Committee. Of course, when you do a collaborative procurement, you have to work with others, and you have to find kind of what the best fit is, and kind of negotiate that best fit across other organisations. But I think this is the first of many initiatives we hope to see over the next few years where we do things collectively across Sussex, if not on a wider scale.
Thanks, Mike. Mark, I know Resources Committee have been looking at some of this, especially the agency issue. Anything you'd like to add at this stage?
Well, we had a deep dive earlier this week on agency, and it was using some of the Pareto charts that we've seen earlier in the pack, really insightful, and I think gave us comfort in relation to both the understanding of the spend, recognition that some of it is actually spend we want, but also that in other areas actions do need to be taken. So I think we had good assurance from Donna that this is an area of focus, and there are a variety of actions, both in terms of reinforcing the approval processes, but also specific actions around recruitment that are in play. So a very good discussion in regard to that. And I think we should also recognise that the year-end outturn, which we're seeing here, didn't happen by magic, and there an enormous amount of work happened in Mike's team to ensure that the multiple moving parts landed as we anticipated. So we should, I think, recognise the work of the finance team in that regard.
Thanks for that, Mark. Hear to that, and congratulations on the accreditation as well. Any further comments for Mike? No?
Yeah. Could I just ask about the payroll hub? Because I've been through an experience where we transfer from SBS, and the performance of SBS went down markedly in that lead up to transfer, and there were real problems about transferring data as well. Have we got assurance built in that actually that's not going to happen here? Because one of the most important things is that staff get paid.
Yes, I know, I understand that, and we were quite rightly nervous when we looked at changing payroll. This is an SBS to SBS transfer. It's a change in the SBS delivery model. So, and where we get some assurance around that is, so we're moving to SBS are going to support a local hub and team, therefore that
Right.
support the providers in Sussex and the commissioners. So we get the blend of a bigger organisation behind, but a team that understands Sussex, and the continuity bit. Some of the key staff, the team leaders, etc., that are part of our current SBS team are going to transfer over into this service in the local way. So that should keep the continuity going as well.
Brilliant.
But you're right to be cautious, and we'll need to monitor that and make sure it works well.
Thank you.
Staff wellbeing is a priority for us, so let's not mess up the payroll.
Let's make sure we pay them.
Could I just add a thanks to all the budget holders as well? So there was a thanks to the finance team to hit the year-end position. I always say, well, we're not the ones who spend the money, it's the budget holders. So we've been working with them, and the budget holders have helped us deliver the year-end position and the control. So that's Kate's teams and the corporate departments as well.
Okay. Caroline, you want to go ahead?
I just wanted to follow on to what Mike said around the support to apprenticeships in the finance team. It's really important to kind of acknowledge that. I think when we think about widening access to jobs in the NHS, they do that very well. They've taken on Kickstarters, and in the team, the support and training that goes on is really good, and people always have really great feedback. So these are examples of it's not a clinical team, but of a team that really focuses on people, not just the money. So I just wanted to say that. So it's really good.
Thank you for that. And on that comment, if we note the integrated performance report, and we'll move on to item 7, which is committee chair reports. Now, the first one is charitable funds. Rebecca Crook, the chair, isn't with us today. Caroline, can I look to you to give us any extra comments you want to make, or David as a committee member? Is there anything you think we should add to the report, or anything you want to highlight?
No, I mean, I think we had a good meeting, and we were able to support some important bids requests for the organisation, and the development of the strategy the implementation of the strategy is ongoing. The board will be asked to make some decisions at the end of June. I'm hoping Zoe is nodding around some of the recommendations that the CFC has made around ongoing resources to support the development of the charity and the implementation of the plan. So that's what I wanted to say, really. Just a heads up. To say yes. I mean, to consider.
Any questions on the charitable funds report? No? Which takes us on to people committee. Giles, anything you want to add?
Nothing to add to what's written there. We continue to kind of work our way around that first employment cycle. We looked at attraction last time. We're looking at integration, diversity and integration next time. There's also been some cross-reference between the committees around just getting some grasp for the NEDs almost on what does the overall structure of the organisation look like at the different levels, and how is that weighted and everything that's within there. And even just the preliminary chat with Caroline this morning, there's a very helpful spreadsheet that kind of captures everything. At the moment, it's geared to kind of demonstrate where the vacancies are across the organisation. But there's some suggestion that we can twist it in some way with the pivot tables to actually show this is what the organisation is looking like.
Okay. Any questions for Giles? No? So shall we move on to Quality Improvement Committee?
Thank you. There's only one that I want to highlight, and that's around the learning from the Ockenden report. Some of you will be familiar with it. It had huge national press around the Shrewsbury and Telford review of maternity services. But it also has wider learning for all organisations around governments, particularly around incident investigations, complaints and concerns about clinical guidelines. We had a good discussion at Quality Improvement Committee about how we should take this forward, and recognise, and Lloyd joined us for that meeting, recognise that actually there may be overlaps with some of our early years services, health visiting and school nursing, linking on from some of the maternity recommendations as well. But there were 3 areas that we wanted to take forward. So further assurance really around processes in some of these areas, and we'll be looking about how we do that. Learning from outcomes across the organisation as well. And again, we wanted greater assurance probably, and that will be through QI, some of the things we've talked about this morning, but different ways of making sure that outcomes from serious incident complaints are widened. And the third area, which is a massive one, and again we've touched on this morning, is around the culture of the organisation. Do people feel safe to speak up if they see something they're not quite sure about, or raise issues and mistakes? All good practice as well, but that obviously needs to be taken forward by us as a board and the organisation as a whole. So very happy to answer questions on on that or any of the rest of the report. Might pass some to Don.
A key point I take out of that, Leslie, is although Ockenden was about maternity services, provide maternity services, but there's some broader learning that we need to take into account and perhaps come back to as a trust board in terms of when we're looking at developing an open culture and giving people the confidence to speak up.
Absolutely.
Okay. Siobhan.
I was thinking actually, Leslie, as well about incidents more broadly, and I was just, the learning from the Ockenden report is very, very powerful about failures in system and process that was systemic in an organisation around management and investigation and reporting of incidents. And I was looking at our quality dashboard in the IPR, and I was just wondering whether the QIC might want to help us to think, how do we provide a way of giving the board assurance about incidents in totality? Because we report around serious incidents, which is one element of it. We also report around incidents that cause moderate harm, which is incredibly important also. But in the context of what you just said about Ockenden and having read the report and understanding some of the failures that we need to make sure we learn from, there is something about what evidence might we wish to bring to QIC that provides assurance about the rigour and consistency of our approach to investigating incidents and learning from incidents more broadly. I don't know what that looks like, but I think in the context of what you've just described, I think there is something for us to think about there.
And we have made a start with a new form of reporting, which actually highlights the top areas. I think there is further to go, and what we want to do is bring thematic reviews around those top 5 areas. Of course, it links to the quality account as well. So greater assurance. And I think one of the things we did talk about was our exec visits to services, and are we targeting the right ones? Because we're often invited in, and obviously those services are ones with good stories to tell, which is great to learn from, but actually do we need to target them in different areas as well? So I think there's a lot to do, and obviously, Donna will have been thinking about this, and very happy we will take the conversation forward and gain further assurance.
Anything you want to add?
I think just to add, what we didn't want to do at QIC was to create something that was almost a self-assessment against a set of standards. I think what we wanted was this to be kind of like a live conversation where actually we all keep the learning from Ockenden in our minds, and we use that as a lever to encourage us to challenge some of the data that we have, to question the levels of assurance about learning and embedding of learning, to actually take that approach rather than have a sort of, a plan that says, yes, we're partially assured against that, for instance.
So maybe we should take this away as an action and look to QIC to continue the work you started.
Yes.
Charles, you want to come?
And I think on that one, it is really interesting around the processes bit. And certainly it's not the job of QIC to be judging whatever it is, but it's when there's an incident and it's downgraded.
Yeah.
I think one of the issues that came from identified at Ockenden was everything was being downgraded. It's not for us to judge whether it should be downgraded or not, but we should be assured about the process. And Howard used a lovely phrase of, and a lot of these are downgraded appropriately.
Yeah.
What appropriately, I think, is the bit for the Neds to be able to dig into, is a process of that helpful challenge to be saying, how do you know it's appropriate? And almost there's a benchmarking bit that says what proportion should or shouldn't be being downgraded and which should be up, because the significance of not downgrading it is very great. So there can sometimes be a huge management pressure to say just downgrade it, otherwise the significance around this is great.
I think that's a really good point. Make sure we've got robust processes around that. David, you want to come in?
Thank you. Just a slightly different point. I guess looking at the paper, the inevitable thought that gets through one's mind is, gosh, this brief is really broad in terms of the numbers of areas that you're looking at. I suspect that it's not inconsistent with quality committees elsewhere. But I think there's, in my mind, there's always the question which goes around: is the agenda too large? Is it sort of doable? And are you able, therefore, to give appropriate time to all of the topics that seem to come through your remit?
Sounds like a question for you, Leslie.
Yes, thank you, David. I mean, the agendas do vary, of course, and some of it because it links into board and the assurance element of it. What we're trying to do is move just from assurance to move more towards the continuous improvement, continuous development part. So I suppose at the moment, I mean, you'll see the obviously the learning from Ockenden report, but we also had a report around community nursing and the neurodevelopment pathway as well. So it is how we spread these things out. And I think over time, we have reduced down, as you know, to every other month meetings now as well. So the meetings are slightly longer. But personally, I feel that we do have spend the time on the most important things to discuss and do have good input from committee members around the table as well. But I would have to leave that open to other people who sit around the table as well as to whether they feel we are having the discussions about the important items and not missing anything.
Leslie, don't take it personally. I'm sure.
Oh, I'm not.
I asked your predecessor, I'm sure, the same question at some stage, and I guess it's from past experience elsewhere where suddenly, you know, quality committees end up with agendas which are just unmanageable because everything has a quality dimension, and therefore it's natural that it ends up with the committee. It's only when you stand back and think, gosh, you know, that's an enormous sort of agenda these guys are covering. So don't take it. I don't take it personally that I'm asking the question.
I'm not taking it personally at all, David.
So I guess what we're hearing is it's manageable as it stands, but there is a continuous exercise in making sure you're concentrating on the priorities as a committee.
Could I just add as well? I think one of the things that we also do, which helps us manage the agenda of the committee, is we work with the other committees. So there may be areas where actually we're only looking at a certain section of an issue, but we will then ask the People Committee, for instance, to follow something up. So I think that kind of shared working, because you're right, quality sits alongside everything, doesn't it? And actually you tend to find workforce tends to sit alongside everything as well. So if we can continue that sort of ethos of working with the other committees, I think that's how we make better decisions around risk and assurance, but B, make sure that the agenda is manageable.
Thanks for that, Donna. And finally in this section we have Resources Committee. Mark, we've got the report in the pack for the 26th of April, but you've kindly given us a one-page report on Tuesday's meeting as well.
Well, I think for the report in the pack, Peter, the conversations around finance and digital today pretty much cover off what we cover there. In our meeting this week, clearly we're looking at month one, and it's very early in the year to draw any meaningful conclusions, but we recognise where we are in the broader budget position. We had some interesting insights around corporate service benchmarking, which allowed us to take some comfort, I think, from where we sit within this, but also recognising there may be areas where we want to invest more, as well as looking at where we might save some money. And then the other piece, I think, which I thought was very good discussion, we touched upon around agency spend, and that will be a continuing area of focus for the committee over the coming months. So happy to take questions on either the report in the pack or the one that was circulated earlier, or yesterday, I think.
Okay, thanks, Mark. Any questions for Mark? No? In which case, I shall move us on to item number 8, which is safer staffing. And Donna, you're going to take us through this.
Thank you, Peter. So just some context to this report. So this is an update 6 months on from the report that you received at the end of last year, which made quite significant recommendations around the establishment of staffing in our intermediate care units, so in our bedded units. And adult bedded units only, I should just classify as well. So from the point of view of implementation of those recommendations, we have implemented shift pattern change from April, and we have also implemented establishments from April which have built into them a clinical apprenticeship posts, the nursing associate posts, both trainee posts and qualified posts. And we've also implemented a process to move our healthcare support workers from a band 2 to a band 3 through using a competency framework. And all of those processes are being overseen through the Community Beds project. And generally speaking, all have landed well with the staff, although there is a little bit of kind of settling, I think, to be fair. So some of the key points from this report, you'll note on the first page that the fill rates, so these are our shift fill rates across the trust, have been very high. So 90% fill rates in the daytime and 98% at night time. I do notice just that there's a slight typo here in that sentence. It says the average fill rates of temporary staffing. It means the average fill rates including temporary staffing. We don't fill 90% with temporary staffing, so I'm sorry, that's slightly the wrong impression. But we use temporary staffing to make sure that we achieve the right fill rates. You can see also on the second page that our registered nurse vacancies have significantly reduced as of April, down from 39% to 6%, largely due to the international registered nurse recruitment that we started implementation of last year, and we're continuing to move into a phase 2 implementation of it as well. What you will note, though, is that the turnover is increasing. So from October of last year to March of this year, the turnover has increased. But I would caveat that with the conversation, I'm not going to repeat it, that Caroline had and that Mike clarified for us as well about that. I also just wanted to highlight the care hours per patient day information, which is section 2.5. So we saw a slight reduction in the care hours per patient day prior to April. So what that shows is actually that our review was correct in that we didn't have the staffing establishments correct. Our templates weren't right. But the new templates that came into place from the 1st of April should improve this so that we're meeting the national benchmark. And then just to finish, as we talked about in the IPR, we are developing how we report quality metrics and linking quality metrics with our staffing metrics so we can see that triangulation of information. And that will also provide additional assurance around the safety of staffing in our intermediate care units. I'm happy to take any questions on the report.
Any questions?
Can I just say that we did review it in QIC, and the one area that we were concerned about was assurance about patient safety. So really pleased to see the chart that's there for the safety indicators. I think that's going to give us a great deal.
Thank you. This, of course, as you said at the beginning, applies to our inpatient units. It's somewhere in this pack or elsewhere that there's some work going on looking at safer staffing elsewhere.
Very exciting. We've been asking for this for years and years, safer staffing in community nursing. So nationally, they have now developed a tool to assess safer staffing in community nursing. Hasn't been released yet, but we have applied for and have received a licence. There's no cost to it. It's been developed by NHS EI as opposed to a separate organisation. So there is no cost to that. We've got the licence, and we've had one person who's gone through the training. We're only allowed to put one person forward for the training at the moment. So I think that was just an initial.
Stay well.
Yes, I know. We chose wisely, Peter. So we're hoping that will come out and be published in the next month or two, and then we will look to think about how we will implement that at the same time as looking at the capacity and demand information that we're just.
I was going to say that should help us understand what's going on in community nursing. Yeah. Giles, do you want to come in?
So even though Leslie chairs a very broad agenda, it is sometimes quite exciting, the agenda as well. And again, for fear of being a broken record on this, it's still very kind of the nursing focused bit, yet it's a very mixed workforce that we have working in these places. Some of the healthcare assistant numbers coming through, and nice to see the totality of what running a ward actually means, because all of that contributes to patient safety. And whether with the community nursing bit coming through, whether at the earliest stages we can build in that totality of what community nursing means across the board of what it is that we're trying to deliver, I think it could quite strike quite a difference, rather than just kind of trying to follow what a national model might dictate in the first instance, push the boundaries on it.
Thanks for that, and look forward to seeing the outcome of that. Any further questions for Donna before we agree the recommendation? No? Okay, thank you. That takes us on to item 9, which is guarding and safe working. And now what normally happens here is Sarah Lighthalers gives us a verbal report, but as she's not here today, she's kindly written something down. And the conclusion I draw from this is we are fully implementing the 2016 Terms and Conditions of Service for Doctors in Training. So I take assurance from that, and unless anyone's got any questions, I will then move us on to item 10.
Thank you. So on behalf of Sarah, I'm just presenting the Q4 mortality review. So you'll see from the report, it's fairly straightforward. We reported 4 deaths in Q4 and none were considered to be avoidable deaths following a review using the National Structured Judgment framework. The average age of the people who died was 85, and the main causes of death were ischemic heart failure, frailty and pneumonia, which would be what we would expect from our patient cohort in our bedded adult units. There's more information in the report, but I'm happy to take questions on that.
Questions, comments?
I think there's a typo, sorry, I just noticed. So I think for the minutes we should probably just capture on page 108 at the top there. So it's from the 1st of January, should be 2022 to March 22. There were 5 recorded deaths.
It says 2011.
Yeah, just
yes.
A digit out.
Thank you. I'll update that.
Okay, thank you for that, Siobhan. Any other comments before we note the report and move on to serious incidents report for Q4? And again, it's you, Donna.
That's right, thank you. So again, a fairly straightforward report. We reported 9 serious incidents in Q4. One of them we have requested a downgrade of, that was an information governance incident. The number is fairly consistent with the patterns of reporting over the last 2 years. The themes in Q4 include falls, and we regularly discuss falls in the Quality Improvement Committee, and we've requested a deep dive at the July committee to look further into falls. What I would sort of give some context to that is we are significantly below the national average when we look at the number of falls per occupied bed days, and that's in our Chloe quality metrics. But there is some learning from these serious incidents in falls, and we at the Quality Improvement Committee just want to make sure that learning has been shared across all of our units and that is being embedded. And then the other point I just wanted to highlight was that the themes for the year for 21-22 include the deteriorating patient. So this is both the identification of deteriorating patients and the management and the escalation as well. So we've had quite a lot of discussions around how best to address this, because we have addressed it at an individual unit level throughout the year. But it's clear from this report that actually we need to take some action that looks at, that we can share across all of our bedded units. So the team are pulling together an improvement plan at the moment for us to have a look at. But one of the things we've talked about is a relaunch of the deteriorating patient care bundle, and also some audit work just to ensure that some of the actions around the News 2 in particular are being embedded in all of our units. Thank you.
Okay. Any questions? Anything? I know QIC, madam.
We have had a look at this paper, and I think obviously happy to endorse it, but I think the interesting thing was reading it in relation to the patient safety report, which shows the incidents, and obviously, as you would expect, the same areas are coming through as the highest risk and of patient safety. So I think that was a real value in the new system of reporting, and as Donna said, why that one's been picked up, and we will be looking at other areas as well.
It's interesting you raised falls, Donna, because one of our governors asked me a question about this the other day, actually. We know the reduction in the number of incidents, and as a board, we've discussed that before, and I take it there's nothing new to add to that. But 7 of those 23 incidents were falls. I just wondered, is that trend going up? You know, it may be a greater percentage of the total, but how does that figure of 7 compare with previous years? Have we got any sort of information on trends, and, you know, is there any cause for concern there?
So we will have that information, Peter. Off the top of my head, I don't know that. I'd need to go and do a look back. We can ask them to pick that up through the deep dive at the QIC. So we look to see if there are any different reasons as to why as well, because I think falls is actually a really broad topic, and some of the things that we need to look at are things at the time of day and the place and the period within which of the patient's stay that they fall. We've had some falls when patients are literally the day of discharge or the day before discharge, and there's a general feel that maybe that's about confidence, and patients feeling maybe, well, confidence in their ability, but also maybe feeling slightly anxious around sort of what's happening next to them, from the point of view of their move, and trying to become more mobile because of that. So we'll ask for that to get picked up in the deep dive, and then we can report that back through to the board, the chair's report.
Yeah, thanks for that. Any further comments?
David.
Sorry, David.
A quick question, although I can accept the fact this may test people's memories as it tested my memory. I've got in my impression, the impression I have is that a number of years ago, in this report, we used to regularly have a number of sharp incidents. I'm conscious that we don't see those anymore. Is that because it's no longer an issue, or is it somehow reported elsewhere?
So I'm probably not the best person to test my memory.
I'm sorry, I'm conscious of this.
How will we deal with the sharps?
No, it's fine. So sharps incidents they wouldn't be reported. They'd have to be a really significant sharps incident to get reported as an SI. So these are only serious incidents. So we report sharps incidents using DATEX, and they come through both the Infection Prevention and Control Committee to make sure that the right follow-up is undertaken, and they also get reported through to the Health and Safety Committee as well. And various actions have taken place in the past around using, there's a type of needle that you can use that's a safer needle from the point of view of the person who's administering the injection. So things like that we've looked at to implement. I know actually just recently I referred to the Health and Safety Committee some concerns from the Infection Prevention and Control Committee around the number of sharps incidents in our podiatry team, to see if there was some kind of other medical equipment that they could use that would make their processes a little bit safer. So that's the kind of governance route around sharps, but we wouldn't have a sharps. I've never known a sharps incident come through as an SI.
Yeah, I'm just conscious of the fact that they used to come through to the board at some stage because I can remember it, and secondly, they were particularly around our staff giving people insulin injections where they were using the patient's sort of needles rather than the method that we would use. And I'm just conscious that we saw this for a couple of years coming through to board, which is why I can remember it, because I would have seen it at board rather than somewhere else. And I was just thinking back that we haven't seen anything like that coming through to board probably in the last couple of years. And that's why I was sort of asking the question. I thought it came through part of incident reporting. And I was hoping that maybe one of the older lags on the board might remember it.
I'm not going to describe our chief executive. I'm going to ask for advice on this issue.
Yeah, I mean, I think it goes back to what I mentioned earlier with Leslie and the role of the QIC, because you're right, David. You know, the way we've reported incidents has evolved over the years in the same way the IPR and the BAF have evolved. I think this conversation brings me back to the previous one, whereby I'm just wondering if there is something about incidents, you know, that we need to report in terms of trends and themes to the board, not just serious incidents, because we probably, back to the Ockenden learning, whilst QIC might get assurance that you're right, David, I think there probably is a flow about trends and themes with regards to incidents, and also completed investigations within the given timeframes and embedding learning. You know, there's probably a thematic piece between QIC and boards that I think might need to be in addition to the board work plan. I know Mike's got his hand up. You might want to. Were you going to refer
to the specific?
Yeah,
if that's helpful. So starting where we overview that sort of detail, the SHARPS incidents come through the occupational health report that goes to the Health and Safety Committee. So we review the trends and themes around SHARPS incidents, and we've been heartened to see that they've been kind of at a lower level than had, as you say, previously been seen a couple of years ago. And actually that's in the context, we've had some blips, but that's in the context of running a vaccination service with a huge amount of, a huge increase actually in the use of SHARPS. So, and actually, but for that particular issue, there was a disagreement and debate across system partners and commissioners. In the end, we made sure we purchased our own stock of those safety needles, and that's what our nurses tend to in the main use now when they go into patients' home, rather than using the patient's own needle that might not be a safety instrument.
Okay, thank you very much. I'm sorry to sort of be testing people's sort of memories. I don't know why it came to me.
I think it's an important intervention, David, because I think it comes back to the general point, as you rightly say, Siobhan, you made earlier on, that maybe we need to look at incidents as a whole and how we report them and gain assurance on them. Okay, thank you for that. We now move on to item 12, self-certification on compliance with licence conditions. This is actually quite important, isn't it, Siobhan? You're going to tell us what it's about.
Absolutely. So thanks to Paul Somerville, our Deputy Trust Secretary, for putting this together. But as a foundation trust, we are required to confirm compliance with the provider licence on an annual basis. So this is here for the board to self-certify the trust compliance with the licence based on the detail provided in the paper, and also to then authorise the Chair and Chief Executive to sign the self-certifications on behalf of the board. This gets published on the Trust's external website, and as I say, is a national requirement for us to do annually as a foundation trust. So the evidence is hopefully fairly explanatory, particularly in Appendix 1, which is page 126 through to 129. I'm happy to answer any questions.
Questions? You're happy? Yes, Leslie.
Why is the section, I can't find the page number, 133, there's a section on quality there that's not been completed.
On, sorry, 133.
133, number 5, corporate governance statement.
Oh, I see. I think there's in terms of the response, the risks and mitigating actions are there. Zoe, we might just need to check what that looks like on the actual document in the response box. We haven't.
So I would have thought it's completed along the same, confirmed the same as the others.
Yeah, we haven't added confirmed.
Empty for.
I think it's an oversight, Leslie. We'll just check before we sign it. Thank you.
Thanks for pointing that out, Leslie. Are there any other? Got Mark. Any other points?
Me, please.
Got Mark.
Thank you. On page 126, Siobhan, we rate ourselves as a rating of 1 in relation to availability of resource. And I just wondered, given the current budgetary position, given our current risk rating, and given the uncertainty that we've discussed around the implications of the cost improvement programme, is 2 more appropriate as a forward look, given where we are at this point in time?
Mike?
Yeah, I know. I'd say this is an external rating that comes from our soft rating, which kind of looks at a number of metrics. And as some of those, and what won't play into that are any of the uncertainties in the planning round. So I'd say currently we are a 1, because it's looking at our use of resources indicators that all then feed through to a one, and they're external indicators. If our plan, once the contract is confirmed, becomes inherently more risky, or our delivery against that plan goes off, then it might come to a two. But these metrics are looking much more about delivery as you go rather than a forward look on risk.
And I recognise that in terms of the metrics, Mike. I think the declaration is a forward-looking declaration, isn't it? That says we are covering the 12 months to March 2023. So that was what was driving my thinking. That says, as I look forward over the next 12 months, there are lots of moving parts. Notwithstanding the broader inflationary pressures and everything else that we don't have control over.
I think that would be then a different line, because the use of resources indicators that do make us a one at the moment. I guess we're talking about our forward look on our finance risk.
Is there a way we can qualify that one, Mike, by saying by the criteria we are one at the moment, but we would know the possibility of deterioration in year or something similar, either in that section or another section?
Yeah,
we have actually noted, we know, so we're clear that we've been looking to the future. We know that.
I think because it could be spun into a positive in terms of self-assessment as a board, which is we are mindful and actively consider our increasing finance risk over the coming year and are looking at mitigations or some. So there's something about.
That meets the criteria of one. We are cognizant of the fact that could.
There's a risk, but we discuss it as a board. That's the positive, and that's kind of what.
Absolutely.
Would that make the point, Mark?
Yeah.
Yes, absolutely. I think it's the recognition that we are clear there are risks, and we're actively managing them.
Yeah.
I don't quite know how that plays within this process, but I think as a forward look, it's probably worthwhile capturing somewhere if we can.
Are you happy to find the appropriate?
I'll talk to Zoe. I'm sure that's
with that amendment. Are the board happy to agree the two recommendations in the covering paper? Yes. Excellent. Before we close the meeting, Zoe, I take it we have had no questions coming in. Just checking. No. Okay. So that takes us to any other business, which I don't think there's any other business, in which case I will close the meeting and note that our next public is on the 30th. Our next meeting is 30th of June. Our next public meeting is at the end of July. So thank you, everyone, for attending today. The end.
Thanks, all.
Thank you.